for me as a fertility doctor, anything that impacts your ovulation impacts fertility. So it might not have come out in the study, but if they're seeing an impact on your ovaries, it's going to impact fertility. And it comes back to that whole, the more things that pile up. So maybe smoking marijuana doesn't cause infertility on everybody, but for someone who their partner also smokes, who they have a little bit of a male factor already, maybe they have a little bit, it's everything's additive. So do I think everybody that smokes marijuana is going to be infertile or have a miscarriage? No, absolutely not. It's a risk factor. And what a risk factor means is it increases the chance of something happening. So the more we can take away, we decrease the overall risk. So say when people ask how common miscarriages are, they are about 15%. So in the general population, the average is 15%. But again, that's not an individualized number. So as we know, women in their 30s, it might be 10 to 15%. Women in their 40s, it might actually be 40 or 50%. So when a patient comes, sees me and asks me the risk of miscarriage, I tend to do it related to her age as well as sort of other risk factors. Because obviously someone with antiphospholipid antibody syndrome or something else might have a higher individualized risk of miscarriage. What is important, as I said, is the risk of miscarriage declines. So whatever number we give you based on your age and your risk factors, that is at the start of the pregnancy. With each week of gestational age, that risk of miscarriage reduces. So even when you're 40, say 2, and you started off with a 40 or 50% miscarriage, once you get to 8 weeks, the baby's growing okay, there's a fetal heartbeat, it's less than 5%. So part of that is the patient, I always want to make sure those patients know it's not 3 months later, it's still not going to be a 50% chance. I wouldn't say you're 100% safe at 8 weeks with a heartbeat, but definitely that's the one where we all kind of take a little bit of a deep breath because we know the risk is quite a bit lower.
Love that. Thank you for that. And for those that are just joining in, I'm with Dr. Kim Garbedian, who is the medical director for Pollin Fertility. And she's obviously a fertility doctor. So we're going to do a deep dive about miscarriage because it's important. It's so prevalent. As you mentioned, it's 15%. And I would say it's probably higher than that just because people will have those miscarriages at home and who've never been to a clinic or even their physician before they even have a miscarriage, right?
Or the lot go undiagnosed as well if they're quite early on. So I think, and always when we say it's common, it's not meant to normalize or minimize. We still know that it's miscarriages are big. As we said before, it has a physical and emotional impact. So it being common is a way for women to know that they're not alone and there's other people going through it, but it still has a significant impact on patients and couples. So, or anyone who's having a miscarriage. But when we talk about the main reason for miscarriage, so when people talk about miscarriage, and I think any area of medicine, we don't all agree about everything. Not every guideline, not every study agrees with other studies. But one thing that I think is pretty universally agreed upon is the number one cause of miscarriage is abnormal chromosomes. So an embryo, and I'm always careful to say that either had the wrong sperm or the wrong egg. It's not always the wrong egg.
Thank you for saying that, right? Because there's an assumption, right? When a woman miscarriage, there's this assumption and the woman automatically, there's like this self-blame, like, oh my gosh, it's me. What's wrong with me? And it takes two to tango. So
it does. And definitely it could easily be the wrong sperm. And what happens when we talk about the embryo is it either has one extra chromosome or usually one less chromosome. So it would be something like an extra chromosome 16 or a missing chromosome 17. So that is why the majority of women miscarry. So, and what we know is that unfortunately, as we get older, the risk of miscarriage goes up because the risk of us having, chromosomally abnormal eggs goes up. Interestingly, I just went to the Acai conference, which is the European Fertility Conference. I didn't go there. I did it virtually from my living room.
Oh, I was wondering. I'm like, I
did.
Okay, cool.
I did. I virtually did it from my couch. But, I noticed that there's like an increasing trend on looking at paternal factors for miscarriage. So whether it goes up with paternal age, which they're starting to find is true, so men over 40, whether it's because they have higher DNA fragmentation. So when we talk about miscarriage, there's been a bias in research and literature on women of course, we, make the eggs. We know it goes down with age. We carry the pregnancies. But I'm happy to see this new trend where they're saying, okay, look, let's look a little bit more into the sperm. And they actually are finding trends when men are older. We're also seeing partners with higher risk of miscarriage. So I think it's important to always say it really does take two to make a baby. And just because we understand eggs a little more than we understand sperm doesn't mean there aren't sperm factors or more sperm factors involved with infertility and miscarriage. And so the important thing when I'm talking about age and egg quality, so that's the chromosome factors. So, and that is the genetic egg quality. There's also something called metabolic or energy, or however else to explain it, the metabolic egg quality of eggs. So when we talk about those two things, they don't always go together. You can have someone who's 40 who has low genetic egg quality, but they have really great metabolic egg quality eggs because maybe they're doing some acupuncture, maybe they're taking lots of good vitamins. You can also conversely have 30-year-old women who have great genetic egg quality. We know they're young, they should have really great eggs. But when we get to something like IVF, we find out their undiagnosed infertility might actually be low, that metabolic egg quality. And so that is a harder one. So the sort of the correlation between age and genetic chromosomes, that's something we know. So that's very solid in the literature. How do we know who has good metabolic egg quality and who doesn't? That can be a little bit trickier. So often it's actually at the time of IVF. And so different ways we see it, we might see it in the fact that we give someone, a 30-year-old with normal ovarian reserve, we give her a certain dose of drugs that should equal this many eggs, and they don't stimulate. There's a canceled cycle because maybe they're not responding to the drugs. It might be that we see lots of follicles, the right amount. So we see 10 or 12 beautiful follicles. We get to the IVF, we put our needle in, and we don't get any eggs. So we're aspirating, empty follicles. And that can sometimes be a sign of sort of not lower genetic egg quality, but actually lower metabolic or energy of the eggs. Sometimes it actually takes us to go to the lab where they don't look great under a microscope. Maybe they don't fertilize well, and maybe they don't convert to blastocysts well. So there's lots of hints when we do IVF for women who have sort of lower egg quality. And again, that is not necessarily correlated with age. You can have young women that have lower sort of egg quality, and you can have women over 40 who have perfect egg quality. So, and those are things. So when you talk about the interventions like, acupuncture, taking your vitamins, taking, not smoking, not drinking, not smoking marijuana, all of those things are going to help your eggs, grow better in that metabolic quality of your eggs.
Love that. And, in Chinese medicine, we actually speak to this. We talk about, let's help the mitochondrial ATP,
yes.
Right? Like, so it's all like, because I say it's like the fuel that houses a cell because it requires energy to create that cellular divisions. And if it can crap out if there's not enough energy, right?
Yeah. And you can also see, and, that's why everybody takes coenzyme Q10, as you know, because we're trying to target the mitochondria. And what we know from research is that women who, as we get older, we have fewer mitochondria, but also free radicals. So what they find even in young women, so they might have all those mitochondria, but when we do IVF, when we put that needle in, so the follicle that's growing on ultrasound that has fluid in it. So we call it follicular fluid. So as your eggs grow, you get more of that fluid. So when we go in to retrieve the eggs, we put the needle into that follicle, we take out all the follicular fluid, and the eggs kind of in the fluid. So the lab gets all the follicular fluid. So what they found is in women who have poor quality eggs or lower pregnancy rates with IVF is they have more free radicals. So lots of free radical action. So if you think of coenzyme Q10, but also that is where acai berries, or I don't always say it right, but acai berry,
yes,
maybe,
acai berries,
kind of comes in, and I see coenzyme Q10 all over. But I don't actually hear a lot of people talking about acai berry, and that's actually a very potent antioxidant. And there's been some studies showing that it actually does really great things for fertility, as well as male factors. So a study coming out of CCRM showed that women who were on the acai berry supplement for 8 to 12 weeks, they actually had more eggs with IVF and higher pregnancy rates. And that's a pretty big thing. And the study they did were on women who had a previous cycle that was unsuccessful. So they took the, acai berry supplement for 8 to 12 weeks. Then they did their second cycle. So that's showing that that is the only intervention that they made. And it actually made a significant difference. And it made a significant difference in patients under 39 and over 39. So that's an important thing.
Do you offhand know what the dosage is? Because of course everyone's going to be like, "Oh my gosh, I'm going to take it."
Yeah, so
Yesterday.
they have so that is and it's in terms of the dose, so they actually have their own CCRM branded acai berry that is a very potent form. I don't know. So last time I checked, we weren't able to bring it over. Even at CCRM Toronto, where I worked, we were not able to get the supplement. It was a lot of work to get it over here. So I do think that's where, I mean, obviously talking to your naturopath, talking to you, talking to me, trying to find, I always think good quality supplements. So that's something that if Tanya was here, she would probably be saying,
totally.
Looking at safe doses and, different ways. So is it better to get it from obviously healthy food as opposed to doing the supplement route? But I do think there's a lot of interesting stuff coming out with acai berry. And also when I was at Hannam, we were also helping CCRM with a study on the DNA fragmentation. And I just saw something online that was showing that they actually did find a significant difference for men with high fragmentation that were put on these supplements. And then they had normalized fragmentation in over half the population of men in the study. So I don't know if that's a full published study yet, but I think the overall message is antioxidants are really great, in terms of coenzyme Q10, acai berry doing things to help the mitochondria, to reduce free radicals. And that also goes with the other stuff we're talking about, decreasing smoking, decreasing drinking. Marijuana is a big one that I get asked about a lot. So, and everybody says, well, really, can all that, and the answer is infertility or fertility is complicated. It involves millions of little interactions and processes on the egg side, the sperm side, the uterus. So anytime I see a couple that's having trouble getting pregnant or an individual that's having trouble getting pregnant, the more things we can pull away, the higher their chance of pregnancy. So even if it's male factor, if you don't have great egg quality, then it's not going to help for us to do IVF. So when people ask me, really, do you think these things make a difference? I do. They might make a micro percentage or a quarter percentage, but when we add them all up, it actually might make the difference between someone who conceives and someone who doesn't. So I do think it's important to pay attention to all of those things.
And I love that you bring this up because, in terms of like the actual meaning of transformation in the transformation world, we talk about, it's about the tiny little habits. It's like micro mini habits that you shift in your life and done consistently over time will create a transformative way of being, which includes your cells. As a woman, your egg cell will be the largest one. As a man, the sperm is your smallest cell in the body. They're all vulnerable. So we could do something with that, right? And for the man that actually gets a clearance on, the sperm looks pretty good. Well, I say, when you take a sperm sample anyway, it's that moment in time. So if you go back, like you were doing pretty clean, and then all of a sudden, next thing you know, you're like doing pot and partying it up, and then you go for an IVF retrieval, it might be suboptimal. So it's like we need to be careful with our lifestyle.
And I think anyone who doesn't support, taking vitamins and doing all these things and doesn't think they have an impact, well, there's vitamin D, and vitamin D is a very well-studied vitamin. And as you know, so it's been linked. So why does it have biological plausibility? So why did people study vitamin D in fertility and miscarriage? Because there's actually vitamin D receptors in the ovary, in the endometrium, in the myometrium. So when I was in my fellowship, Dr. Liu and I published one of the early papers on vitamin D and IVF. And what we found is women with very low vitamin D, those deficient levels, and even some of the insufficient levels, had lower clinical pregnancy rates with IVF. And the reason I highlight vitamin D is there was just that study last week coming out of Fertility and Sterility that said it also, low vitamin D is a risk factor for miscarriage. So, and that makes sense. So we've got something that might affect implantation and the chance of getting pregnant, something that might impact miscarriage. And then even more interesting, which isn't quite in the news a lot right now, is the impact on AMH levels. So as I said, vitamin D has receptors in the ovary, the lining, the uterus. And there is actually some studies going on right now that is saying that maybe sort of superdosing vitamin D can have a transient sort of rebound in AMH levels. And I'm not saying go out and take lots of vitamin D, because remember, it's a transient spike, and the studies are very early. So when science starts, there's usually low sample size studies that don't have great methodology. So it's way too early to say if this is actually a thing. But why, as a fertility doctor, I find it fascinating is does it mean if we give you a high dose of vitamin D, maybe 7 days in that luteal phase before you start your IVF cycle, is that transient sort of upswing that they're seeing in AMH, because AMH is active, like growing follicles, will that translate to some kind of surge in AMH that might get you to recruit 2 or 3 more follicles?
Interesting.
So, and like I said, the studies aren't there yet, because even just seeing that the studies showing that kind of surge, too early, the quality of the studies aren't there, the numbers aren't there, but it's interesting enough to say, that's actually pretty interesting. It won't make you grow eggs, because we know you're born with all the eggs you have, but if that transient kind of sweep might be enough to get 2 more eggs, which for some women might make a difference. So what's needed is more studies to confirm that what the dose is for that, how soon before your cycle do you have to take it, how much does it increase your AMH, but also does it matter? Because if your AMH goes up and you don't get more eggs, doesn't matter. So like I said, I'm not advocating people go out there and hyperdose vitamin D, because when you look at studies, having too much vitamin D isn't a good thing either. So there's sort of an optimal kind of vitamin D level, but there's also sort of a toxic vitamin D level. So
but let's speak to that though, right? Because I don't know, is it like 75% of North Americans have deficiency in vitamin D?
Correct.
Right?
Yeah.
So, I mean, it's so prevalent, and it is important to look at. And so, I love what you say. It's like, well, don't all just run out and get vitamin D, right? And the reason being, it's like, I think you should be monitored, and it's a simple blood test. You can just check it out. And yes, it's a paid one. You have to pay, but it doesn't break the bank. Let's see what your baseline is, and perhaps it can improve, and see a specialist about this, right?
Yeah. And we check them. So I check the vitamin D levels on all my patients that come see me. And I would say, it's around that 75% of patients, with the exception of patients who have read about vitamin D and they're on vitamin D. And for them, usually they're in the range. Sometimes there's patients who are taking a supplement that we're like, oh, you should probably increase it because, your levels are still on the lower side. I've seen patients with almost 0 in the terms of their vitamin D, so deficient. I've seen patients that are on supplements that we're like, oh, you might want to kind of bring that back again because it's really high. So I think, and that's the message is, yes, I actually think most people in Canada, if not everybody, should be on a vitamin D supplement. Yes. We're doctors and health practitioners, so we're not going to tell people to go get some natural vitamin D and kind of suntan for melanoma. So I do think people should be on vitamin D supplements. But as I was saying, because of the pregnancy information, the miscarriage information, maybe this impact on AMH, we don't want people just taking massive amounts of vitamin D. Like you said, do it with your practitioner, get your levels monitored, make sure you're in the right level. But as I said, for people who say taking your vitamins and being healthy doesn't matter, well, vitamin D is the prime example. It appears to affect all aspects of fertility. So and that's the one we know of. So who's to say all the other nutrients don't have a significant impact as well? So I think overall, being healthy is never a bad thing. You're never going to see a doctor say don't be healthy. And everything in moderation, right? So most in terms of we don't want you to drink alcohol. So, and I tell my patients all the time, like, once you're pregnant or you've ovulated and we think there's a potential that you're pregnant, no drinking, like just don't do it. But, having a glass of wine here or there, I think that's okay. If you're drinking heavily every night, that's a different story. So, smoking is different. Smoking's a no. Like, we're not a smoke a little bit or smoke a lot. Doctors are usually like, please just try and cut down smoking, because we know it impacts, fertility, impacts ovarian reserve. We know it impacts, a pregnancy. We know it impacts early, in terms of sudden infant death. So doctors will always say that one. Marijuana.
Wait. I'm just going to stop you there for one moment, because again, we're so focused on the women. So again, ladies that are watching this, I hope that you bring your men and they actually sit down and watch this with you. Because I want you to speak to the men too. Are you going to say, don't do it, or, oh, it's okay? Right.
I would say absolutely the same advice. And I think the bias in the literature is definitely on women in terms of fertility and even miscarriage. And as I'm excited that trend is changing, and, we're investigating sperm more. But when you think about sperm and eggs, they're all gametes, like they're all meant to produce babies. So if vitamin D is affecting eggs or miscarriage, it's going to be affecting sperm too. We might just not know how to measure it yet. So I think, you take your vitamin D, you take it, you take your coenzyme saying P10, you take it. You don't drink, you don't drink. So, I think it has to be fertility. If you're alone, your team is obviously your fertility team. But if you do have a partner, they should be doing the exact same interventions. Like if you are trying to eat healthier, it doesn't help if someone else isn't trying to eat healthier. If you're trying to stop smoking and someone else is smoking, and it's not only to have that support, but like smoking affects sperm. There's studies that show that smoking increases DNA fragmentation, which we know has an impact on fertility and miscarriage. So, one of the ones I get asked a lot about is marijuana. So what's the story of marijuana? And marijuana is a hard one to study. So I don't smoke marijuana, but I do know that marijuana sometimes has CBD, sometimes has THC. There's different concentrations, there's different strains. So when I talk to couples and I say, or patients, and I say, do you smoke marijuana? I don't just say yes or no. I need to know, how often? Are you doing this every day? Are you doing this multiple times a day? Are you, ingesting it? Like, what are you doing? Like, what does smoking marijuana mean to you? Because all of these things seem to be dose affected. The more you do something, the more likely it is to affect the outcome. What's the literature say? Well, it's hard to test it because most of the time it's, do you smoke marijuana or not? So you might have some people in a study that do it a little bit, some people that do it a lot. So, but what is kind of coming out in the literature is that maybe it impacts female hormones. So, and it might impact ovulation. So it can delay ovulation 1 or 2 days. Some studies hinted maybe at the extreme, it might cause anovulation, but I think just a delay. In the study, it did not show that delay, necessarily translated to lower pregnancy rates. But for me as a fertility doctor, anything that impacts your ovulation impacts fertility. So it might not have come out in the study, but if they're seeing an impact on your ovaries, it's going to impact fertility. And it comes back to that whole, the more things that pile up. So maybe smoking marijuana doesn't cause infertility on everybody, but for someone who their partner also smokes, who they have a little bit of a male factor already, maybe they have a little bit, it's everything's additive. So do I think everybody that smokes marijuana is going to be infertile or have a miscarriage? No, absolutely not. It's a risk factor. And what a risk factor means is it increases the chance of something happening. So the more we can take away, we decrease the overall risk. So in men, for instance, so what does marijuana do? So we've seen studies that it can decrease sperm counts by 29%. Again, they didn't necessarily see that translated to lower pregnancy rates, but the idea of that is, well, if it's decreasing sperm counts, it's doing something to sperm. So again, we might not be able to measure the true impact of what's happening. So the answer is, don't smoke marijuana when you're trying to get pregnant.
Whether or not your parameters look normal.
Correct. So I think the important thing is that, just because we can't see the impact doesn't mean it's not a problem. And what I mean by that is if it's decreasing your sperm counts by 29%, and you happen to be a man who has 300 million sperm, when I look at your sperm test, it's still going to be great. It might be 100 million, who knows?
Right.
And he might say, I'm totally fine, but we're missing the fact that it actually does impact his sperm. It's just, we can't see it because he's still within the normal range. And being in the normal range for all these things is great, but if it's impacting, maybe it's impacting something that the semen analysis, the DFI isn't quite testing.
Well, okay, so I'm going to have to cut in here because let's talk about normal, even though we're completely going off topic, but not really. This is all about fertility. So, because normal, I think the bar has gone down when it comes to sperm count, right? Because 1940 sperm count was different than they are now. And it's what's normal now is a lot lower than it was for in 1940. So what the heck? Right?
Yeah. So I definitely think that's changing. And they've actually changed the World Health Organization, normal values. And, and sometimes when I look at it, I always used to tell people, even when it was 20 million was the concentration, you don't want to be 20 million. Most of the patients that come see me, it's 50, 100, 200 million. So even when I'm seeing someone hover at 20 or now with the new guidelines, 15, I'm I don't know, we need to repeat this because this is on the border of it. So normal is for sperm in a population, fine. But I do know the men that tend to hover around that normal value, we have to keep checking because there might be something we're missing. And like I said, sometimes it's transient. I mean, sperm regenerates. So, what happened on one sperm test can be completely different 3 months later. So I do think it's always important when you're doing a fertility workup is to do multiple sperm counts because losing the sound a little bit, but multiple sperm counts because you might be missing a good day or a bad day.
Yes, thank you for speaking to that, because I say this all the time to patients. I'll say, just because you had one test doesn't mean that that is what it is, because it changes like this, right? So retesting is always great. So let's kind of get back on track, and then we got to cut this one short. Well, that's actually not short, but anyway, we talked about chromosomal issues, so I talked about, is it the eggs or embryo, or is it the environment? So we haven't really talked about the environment piece.
Okay.
So the uterus, right?
Yeah. So the uterus, absolutely has an impact on miscarriage. And when we say most miscarriages are the most common reason for miscarriage is something being chromosomally abnormal, it means there's a degree where the rest are. So what else would cause miscarriage? So, when you look at things that we know, so the environment isn't just about sort of how you're making the sperm and the egg. So for instance, autoimmunity. So we know Hashimoto's or thyroid autoimmunity. So that is not necessarily in the environment of the uterus, but it's sort of a whole right. It impacts people systemically. So that could be one of the other causes. There are things like antiphospholipid antibodies. So that's going into the idea of autoimmunity, and that can impact sort of systemic, but also the uterine environment. When you're thinking of the uterus specifically, there is either congenital or acquired sort of issues with the uterus. So that would be maybe you were born with a heart-shaped uterus, or maybe you were born with a piece of tissue down or called a septum. And that can sometimes be a cause, and that's sort of something within the uterine environment. It could be something that comes up later. So a fibroid that's growing, for instance, that maybe wasn't a problem in your first pregnancy, but now that fibroid has kind of grown and grown more into the uterine wall in terms of a polyp. So there's all these things that can either have been there all along or things that just showed up that can impact the environment of the uterus. Now there's a lot more sort of studies going on about receptivity and at the receptive level, looking at things like the microbiomes in the uterus. So that goes back to it, infections in the uterus, something like an acute or chronic, what we call endometritis, which would be, an infection. Changes in receptivity. So some women just have issues with how receptive their uterus is or the window of receptivity. So there's all these things that either affect by environment, systemically, or immediately impact the uterus that can also lead to issues with miscarriage.
Right. And the only other thing that wasn't mentioned, I just want to add that in, is something like if you have actually scarring from in the uterus, right?
Correct. Yeah. And I actually find the scarring interesting. And I don't know if you want to talk about PRP in a completely different.
We should totally do that on a separate one. Listen, all these things, we could do micro topics and they're all so interesting. And I find this,
Yeah, I would find PRP is usually like a 5-minute, but it's interesting enough on its own too.
Yeah. I think we need to do that on its own. I love it. And then more and more people are doing it. Have you been doing it? And see how we're going to talk about it anyway.
Yeah. So in terms of PRP, so for everybody who's watching, so what is PRP? PRP is platelet-rich plasma. So you get it by taking a blood sample. We spin down the blood and we take the serum and all the good stuff. And what is in the good stuff
yourself,
that we think
from
yourself, exactly. And what we think is in there is possibly healing factors and growth factors. So it has been something, PRP is in every part of medicine. So they're looking at it for alopecia for hair loss, to try and make hair grow because of the growth factors. We're putting it into our face. So you've heard about sort of Anfire facials and PRP microneedling for anti-aging. They're using it in MSK and sort of sports medicine to try and regenerate things. So it's something that everybody's investigating right now because it's interesting. Healing factors, growth factors, sounds good for fertility. So where we find the most research going when it's either related to miscarriage or fertility would be the uterus. So the uterine lining. So one thing that can be a risk factor for either failed implantation or miscarriage is a thin lining, so a thin endometrium. And so the thought is if we either inject the PRP into the uterine muscle or we infuse it into the uterine lining, will it grow the lining. So if we grow the lining and the lining gets thicker, is it possible that that's going to decrease the risk of miscarriage or decrease, failed implantation? So, in terms of it, I don't think the studies are there yet. And that doesn't mean it's not a thing. So I always tell people there's two types of medical things that have been researched for 20 or 30 years that have multiple good quality. So good quality would be high sample size, randomized controlled trials that say it's not a thing. So that means it's a low probability that it's something that's going to make a positive intervention. PRP is a little different. It's exciting now. There's lots of small sample size studies. There's lots of, lower quality studies, which is normal when there's a new idea because people are trying to figure out if it's something or not. So I think we need to wait until we see those randomized control trials and wait till we see meta-analysis and big sample sizes. But it's interesting enough that you don't want to discount it. And if people never studied good ideas, we would never advance in medicine.
100%. And
right?
So for you, have you yourself used PRP on patients?
So we did at Hannam. So there was some of the doctors there were doing we didn't see a huge impact, but I wasn't personally involved in that. So I don't want to comment too much on whether it worked or didn't, just because I think it's something that is interesting. And in medicine, there's early adopters and people that have to wait until the guidelines. So I do think it's important that people are studying this. And where I find it the most interesting is, could it help women with Asherman's? So either preventing Asherman's or helping those tissues. So
tell people what Asherman's is again. Yeah,
exactly. So one of the things that I, see a lot of patients with is Asherman's or scar tissue. So scar tissue generally forms when you've had some intervention on the uterus. So it can happen when you have a polyp out. It can happen more commonly if there's a fibroid that's taken out, or after a miscarriage, if you've had surgery to complete a miscarriage. So, in terms of once you have it, it is very hard to fix it. So scar tissue, it forms on top of the endometrium and it impacts how the lining grows. And what we know, it's obvious, is that, embryos need that beautiful endometrium. They need the blood flow. They need to implant. So if you have a scar on top, it decreases pregnancy rates. So for me, when I think, okay, well, it promotes healing, it helps growth. Can it, once you clear all the scar tissue off, so once you remove the scar tissue in the uterus, can either injecting it in the myometrium or infusing it help that lining grow back? Because one of the most common problems after you've had scar tissue removed is that your lining has been damaged and it's thin. So you used to have a 1 centimeter lining. Now you can't quite get it past 5 or 6. So can either the injection or the infusion make it grow? Or is it better when you're doing the surgery? So when you do a fibroid surgery, is infusing that sort of PRP in there going to prevent scar tissue?
Yes.
Right.
So makes more sense to me. Yeah.
Right. Because I'm sort of more, if we can prevent something from happening, the better. So, and the answer is, I don't know, because I don't know of any of those studies happening. But I do think for me, that's kind of the area. Because if you think of the places in plastics or derm that are doing it, they're actually putting it in scars to see if they can, decrease scar healing. Or you see, when they do the microneedling PRP on skin to get rid of the acne scars. So there's a lot in other disciplines. So in medicine, we need to look into other disciplines and see what they're doing and say, okay, well, if it can fix this kind of scarring, can it fix that kind of scarring? And like I said, I don't know. Is it possible that, that's one of the sort of research areas Pollin's going to look into? It's possible. So I think, but I think there's definitely people doing it now that are sort of designing, well, what protocol is the right one? Is it the injecting in the muscle that's myometrium of the muscle of the uterus better? Is it the infusion? And as you know, it's always, well, maybe the studies aren't showing anything because we're not doing it right. So maybe the fusion needs to be more concentrated. Maybe it's like microneedling where you need multiple little injections. We don't know, but I definitely think that's one thing that I'm interested in learning more about. And like I said, just because there's no evidence, it doesn't mean something isn't a thing or it's not interesting. It just means it might be too early in that pathway versus, like I said, something that for 20 years we said isn't a thing, probably less likely that it's a thing.
So interesting. And then I'm going to go back to my field of medicine, which is acupuncture. And we've seen, when we increase blood volume into the uterus, we have witnessed and seen women that have Asherman's and they go on to have babies. Like they were literally told, okay, I think you need a surrogate. This is not going to happen. and we've changed it around, which is so fascinating, right? So, but there's not enough clinical proof, unfortunately, about the effectiveness of that. But I've seen it in action, so it's kind of cool. So, same with the PRP, like. I think we may see it in action. And if I might add in one other example, years ago when I wrote my book, Pathways to Pregnancy, back then there was a trend towards doing augment. Do you remember augment?
Yeah.
Right. So it sounded so good. It's like, it has to work.
I want this.
Right. We want it to work.
Yeah.
Because they would, basically take the stem cells from the ovaries and then put it at time of Acai, I believe, right?
Yeah.
And they inject it into the egg to see that maybe that's going to help with the energy of the cell to help.
Yeah.
And I've had actually patients that did it, but again, it's like it worked, but could it have worked despite it, right?
How do we know?
There wasn't enough proof to show that it works, so they've kind of basically stopped using that protocol. So I don't know, maybe PRP is a totally different thing, but
it's hard to say. Know. It's hard to know. And I think the hard thing about fertility studies, and the reason why I think it's interesting to look at PRP and Ashman's, is it's a very defined population. Yes. And so when people look at, well, does interlipids work or all these different things, the problem is if someone has unexplained infertility and they're in this study, it's not all the same reason for unexplained. So maybe it's a tubal factor that we didn't pick up on tests because it's more of a functional tubal factor than actual blockage. Maybe they have a problem with male factor that, again, we either missed, or perhaps maybe it just hasn't even been discovered yet. So unexplained infertility isn't every couple or individual having the same unexplained infertility. It actually could be thousands of different things. So the hard thing with studies is we're like, does interlipids or PRP work on unexplained infertility? Well, we put all these people in a study and maybe only 5% of those people have autoimmune issues or immune issues. And then we say, okay, these things don't work for these things because we did this study. And so I find that the hardest thing about fertility is doing studies. So when you're checking thyroids, it's like, thyroids, you do what's their TSH, what's this TSH, you do an invention, you see, and it's a very clear cause and effect. The difference is we have no idea if this population that we're studying has anything similar. Maybe one person has 4 reasons of unexplained infertility, the other person has 1, and they're all a different intermix. And then we say interlipids don't work. So, I find my style as a physician is being very open-minded. So, I always sort of think, does it biologically make sense? Is it safe to do? Is there too much of a cost for patients? Because I think when we talk, there's physical harm, but also charging people something that has no value isn't good either. So you have to kind of weigh the risks and benefits. But just because interlipids didn't work for these people doesn't mean there's not someone in that study it worked for. It's hard to tease all that out. So I think that if you said, what is the hardest thing about infertility and miscarriage research? That's it. It's so hard to design a well study with a good sample size. Yes. So the reason why I say PRP and maybe Ashman's is interesting is because that's a little different. Like you could definitely find patients who had no problem conceiving before, had Ashman's, now have problems conceiving, because that sort of decreases the chance that there's other factors, because before the scar tissue, they didn't have any difficulty conceiving. Right. And then it's a very clear population to study, but at the same time, I imagine it's possible. I always think if I have an idea, I'm not the smartest person in the world. So I imagine some other person is actually researching this right now as we speak. Because whenever you think that's a good idea, I imagine millions of other people are thinking, hey, what about PRP and scar tissue? So I imagine by the time this airs, we might see something come across on PRP and scar tissue. But I do think that is the challenge. So if you said, what is the greatest challenge for fertility and miscarriage research? That's it. And how can we study things that are similar when there's so many reasons why people have difficulty getting pregnant or miscarry?
Absolutely. And so I want to thank you for that. And if I might just comment one thing on a personal note, it is really tough. It's like, as a patient, there can be, it's like a menu of things, options. And it can be confusing and overwhelming. It's like, what should I do? Like, what direction should I go? Should I take the intralipid? Should I do PRP? Should I, right? And so, and some people feel comfortable and they say, Mary, you know what? I actually want to do the everything but the kitchen sink approach because I'll feel good about it. And then other people will be, again, the opposite, will say, I think that will be overwhelming for me. And I don't want to do that. And I'm not a person that normally would even take a Tylenol. So it just does not work with me. Right. So for myself personally, I was offered the intralipid. Back then there was no PRP. And I actually had to go inward and say, you know what? I actually trust that my body can do this. And I opted not to do it. And thankfully I have my kid, but I can also see completely the other side and say, you know what, if it's not going to harm me, why not?
What if you're the 5% that the study was actually meant to study? I mean, I think it's important. I think as a fertility doctor or a doctor looking at miscarriage, I'm a guide. I am telling you what the evidence is, and then together we're going to make the plan. So I'm not telling anyone what to do. I'm kind of telling them, like you said, all the different options that are there and helping them work through it and personalize the plan. And that's why if you practice the same medicine on everybody, you're not doing the right medicine. And, and I kind of look at it as patients are going to Google. So I am an evidence-based doctor. I read the literature, I read the evidence, I practice according to guidelines. That is what you want. So you want to go to a doctor that gets that, but you also want to go to one that says, but I accept that there's things that we just don't know yet or completely understand. And if a patient comes to me and wants a specific test or, wants, a specific intervention, if I just say no and don't have a dialogue with them about it, they're going to go home and Google it anyways. They're going to go home and maybe get a second or third opinion and find someone else that does. So the better approach is saying, let's talk about it. So this is what you're worried about. You're worried about whether you have this, bacteria, or maybe you have an autoimmune thing, whatever it is, tell me what you've read. Tell me what it is that's causing the anxiety. What tests do you want? And then I don't say we're going to do everything. I say, let's talk about the evidence. So this is the test you're talking about. This is the evidence that's in the literature. This is why it maybe does or doesn't apply to them. Because sometimes when you read a story on the internet, you think, oh, what if this is me? And I'm like, don't worry, I've already checked your thyroid antibodies. We're good. Check. You've already done that. So sometimes if I didn't have that conversation, I may not have known that the patient just wanted to know if she had Hashimoto's. And I actually have a test result to say she doesn't. So, So because the word immune or autoimmune means a lot of different things. The important thing is, yes, we want to practice based on the evidence, but we want to listen to what the patients are saying, because we cannot stop patients from Googling. And I think Googling is good. I Google, you Google, everybody Googles. Google educates patients. It helps them advocate for themselves. It allows them to have community. Does decrease anxiety in some senses, because it makes you feel a sense of control. It can go both
ways,
and it can increase
just
anxiety.
Misinformation too. So that's where I go. I like Dr. Google to a degree, but then at some point people can get lost in misinformation. And so I just want to bring us back to what you just said, all of what you said, which bottom line, you people that are listening to this, it's like, find a physician that will listen to you and that will work with you versus having to appease your doctor. Because I do get people that will tell me, it's like, oh, like my doctor wants me to do this. It's like, well, it's actually your body. You get to say. And so you need a physician who will listen to you, who will value what you say and, be more open. Right.
Yeah. And even, I've had patients who show me a study that maybe I've left, not a study or a test. So there's one particular test, which I won't talk too much about, that in 1 week, it must have been all over social media because all of our patients were coming in and asking for this test. And, I was talking to their doctor in the hallway being like, have you heard of it? And we didn't know what it was. We're like, what is everybody talking about? And part of the instinct as a doctor to say, well, if I haven't heard of it, it's not a thing. I'm not like that. I'm like, look, if I haven't heard about it, maybe this is a big world with a big universe. And, maybe there is something to this. So I Googled it to figure out what it was. And then after I saw what it was, I did the actual Dr. Google method, which is going to PubMed. So PubMed is where doctors put information and see what research is out there and what studies. So I sort of listened to the patient, looked into what they were saying. I didn't dismiss it because it was something I do or wasn't something I'd heard of. And I actually did a lot of investigation. And then I came back to the patient. I said, these are the reasons I don't want you to do the test. Like, this is the evidence. This is not only the evidence that's in the literature, but this is why biologically it just doesn't make sense. Like, it's not testing what you want. But I'm not going to dismiss what you want, because what I'm hearing is you want to know about your uterine environment and implantation. And good news, we actually have tests that can do that. We can do an endometrial biopsy. We can do an endometrial receptivity test. We can do the there's so many things I can do. So that worry that you had, if I just dismissed you and said, I'm not doing that test, they would have either kept going or lay awake at night thinking, I'm missing something.
Yeah.
I didn't have this test, I'm missing something. But instead, I realized, I don't know if they necessarily wanted this test. They just wanted me to investigate the thing they wanted to investigate. And we did. And she went on probiotics and she was happy. But I think if you dismiss patients, then it doesn't help me or them, because they're either getting their information from another source. And like I said, I want patients to Google, but I am their evidence-based check, and also to see if it really applies to them, because sometimes a study is interesting, but it may not apply to them, or to decrease their anxiety. Because sometimes I can say, don't worry, I can decrease this. So I always tell people, right, Google, but if something's keeping you up at night, email my office, call my office, we'll figure out and we'll talk about it, because 5 minutes talking to me is usually worth 12 hours of Googling anxiety reduction, right? So I can do it a lot quicker, because I can kind of package the information in a way that applies to the patient.
Of course, and with understanding. So,
yeah.
So thank you for that. I think we'll wrap this up, and we're going to have to create another one, and we're out of time today for sure. But I really appreciate your time and energy and passion upon this. Like, it's clear that you are here. That is, you're definitely for the patient, and you advocate for the patients, which I love. And I've always heard that about you anyway. So that's why I was excited to be able to interview you today. So thank you so much, Dr. Garbedian. And if you want to check Dr. Garbedian, you can go to her Instagram at this moment, and it's Dr. Kim G.
I believe it's just Dr. Kim MD, maybe.
Oh, okay. Well, you know what? It's going to be in our show notes. So look through our show notes.
Absolutely. I should probably know that, but I'm fairly new to Instagram. But I believe it's Dr. Kim MD.
Okay. I'm sure it'll be fine.